Ladies and gentlemen, please join me in welcoming Dr. Boris Zevin, and his talk is Training the Best Surgeons Takes More Than Textbooks.
Thank you very much. Imagine yourself in a modern operating room. It's a room the size of approximately 2 average hotel rooms. The temperature is cold and the lights are bright. As you look around the room, you notice a surgeon, an anesthesiologist, a scrub nurse, and a circulating nurse. In the corner of the room, you notice 3 learners. There is a medical student, a surgery resident, and an anesthesia resident. Technology is everywhere. You see an anesthesia machine that monitors the patient's heart rate and blood pressure. It helps deliver the anesthetic that keeps the patient asleep and pain-free during the operation. In the middle of the room, you see an operating room table with 2 large overhead lights. On each side of the table, you see 2 large monitors. They help surgeons like myself perform minimally invasive keyhole operations. In the corner of the room, you see a large metal table. It has a sterile blue drape on top. On top of that table, you have surgical instruments, surgical devices, sutures, and gauze. As you look around, the surgical team is getting ready to perform the operation. As you think about it, you realize how valuable, limited, and expensive operating room resources are. Do you know how much 1 hour of operating room time costs? Approximately $2,000. Now, after the COVID-19 pandemic, we have approximately 200,000 patients in Ontario waiting to have surgery. Do you think surgical skills are related to patient outcomes? Well, across many different studies, research has been able to demonstrate that surgical skill is linked to patient outcomes. This means that surgeons with higher technical skills and better behaviors have better patient outcomes. My name is Boris Zevin. I'm an associate professor of surgery at Queen's University, and I'm also the medical education scholar. My clinical practice is focused on general surgery. As a medical education scholar, I'm interested in studying new ways of teaching medical students, surgeons, physicians in training, and physicians in practice. Why am I so passionate about scholarship in medical education and research? Well, because I truly believe that without high quality, rigorous medical education, we will not have competent physicians and surgeons. And without competent physicians, we cannot expect to have superior patient outcomes. Before we discuss strategies to teach the surgeons of tomorrow, we must understand the history of surgery as a profession. Now, surgery as a profession did not begin until the early 1800s. In the medieval times, surgeons were often barbers. And in fact, we still see a reference to this today when you look outside of the barber shop to a barber pole that has 3 colors. It has the red color, the blue color, and the white color. Red color represents blood, blue color represents veins, and the white color represents gauze that was used to stem the bleeding. In the medieval times, surgeons predominantly performed dental extractions and amputations. You may not be surprised that the outcomes of surgery in the 1800s were not good. Patients had a higher likelihood of dying from an operation or the complications after surgery than actually surviving from an operation. Why may this be the case, you may ask? Well, infections were common because aseptic techniques were yet to be invented. Anesthetics were not invented, and as such, the fastest surgeons were the ones that were the best surgeons. Surgery as a profession did not begin until the 1900s. In the 19th century was the century of many firsts. It was the first use of ether as an anesthetic. It was the first use of carbolic acid as a disinfectant. Antibiotics were invented, and the first metal hip replacement was performed. This was also the century when the pioneers in surgery were looking at different ways of delivering surgical education. One of these visionaries was Dr. William Halsted. He was an American surgeon who finished his medical school training in the United States. And then in order to learn the craft of surgery, he traveled to Europe to spend time with the leading surgeons of the time. In Europe, he learned about aseptic techniques, about use of ether as an anesthetic, as well as the apprenticeship model for surgical education. When he returned to the United States, he introduced the apprenticeship model of surgical education in North America. Now, within the apprenticeship model, the learner continues to practice under the supervision of their mentor or the senior surgeon until the learner is able to demonstrate the required competencies and be safe for independent practice. Do you ever wonder where the term resident comes from? It comes from the times when the learners were actually residing in the hospital. This is why we still use the term resident today, even though the trainees are no longer living in a hospital. Traditional surgical training is well described by the term see one, do one, teach one. What that means is that the trainee would observe the operation that is being performed by their mentor. The next operation they will be doing under their supervision and guidance. And the next operation, they would train a junior learner how to do that procedure. Now, the apprenticeship model of surgical education worked. It produced world-class surgeons for over 100 years. But towards the end of the 20th century, the field of surgery began to change dramatically and rapidly. There were introductions of new technologies. For example, minimally invasive or keyhole surgery was introduced in the 1980s. Robotic platforms were introduced in the 1990s. And the first surgery, which required removal of the appendix through the mouth, which is called natural orifice and luminal surgery, was performed in the early 2000s. With this rapid explosion and evolution in the technology within surgery, the restrictions in work hours for the residents, and the decreased tolerance of patients for complications, the status quo of how we teach surgeons and physicians was no longer acceptable. Now, I want to introduce you to the concept of deliberate practice. Deliberate practice is a term that was coined by Professor Anders Ericsson. He was an international expert in human performance and expertise. By doing a number of studies with various elite performers, including athletes as well as musicians, he realized that there is a set of components which he deemed deliberate practice that were always associated with expert performance and expertise. Now, deliberate practice is not the 10,000 hours that you've heard Malcolm Gladwell speak about in his book. Deliberate practice is a set of specific conditions that have been uniformly associated with expert performance across different domains, including surgery. Now, deliberate practice requires 4 different components. The first is a learner who's motivated to improve. Second is a task with a well-defined goal. Third is provision of feedback. And fourth is ample opportunity for repetition and practice. Now, let's think of how deliberate practice can work in the real world. Let's take an example of a novice learner. We're going to think of a medical student. So the novice learner is trying to learn a basic surgical skill, which is suturing. So the learner will assume is motivated to improve, and they have a well-defined task with a goal to learn suturing. Without feedback from their teacher, they're likely to stagnate in their development and not develop the skills that they need. And then for the fourth component of deliberate practice, which is ample opportunities for repetition and to make mistakes, we have 2 options. One is we can let the learner come to the clinical environment, participate in the operating room, and suture all of the incisions. Or the second one is to think about a different way of avoiding the learners having to practice on patients and make mistakes. So simulation laboratory provides a wonderful opportunity for learners to engage in deliberate practice. In that environment, the medical student will be able to practice on synthetic tissues with real instruments to learn and master the skill of suturing. Once they've demonstrated their skills in a simulation laboratory, they're able to come to the clinical environment and actually participate in patient care without having to subject the patients to the unnecessary risk in the early stage of their training. Now, simulation-based training is one of the areas of focus within my research program. We've conducted a series of studies with medical students and residents to demonstrate that active participation, deliberate practice within a structured training curriculum in a simulation laboratory has been shown to significantly increase the technical skills and the non-technical skills, which are communication, collaboration, and leadership skills within the trainees. As an example, we were able to show that a third-year surgery resident can engage in deliberate practice and successfully complete a simulation-based training curriculum in a laboratory and gain the skills, both technical and non-technical, to the level of a fifth-year resident in surgery. I believe now we have sufficient evidence within medical education to recommend mandatory participation within simulation-based training curricula for both medical students and residents prior to engaging in patient care. I believe that our patients should expect nothing less. Now, we've spent some time thinking about strategies to make our medical students and our residents even better. But what about physicians in practice? They are the ones that are teaching the next generation of medical students and residents. Are they good doctors? Are they good teachers because they're good doctors? You might be surprised to know that as physicians, we were never actually taught how to teach. So the other component of my research interest is thinking about strategies for how to help physicians in practice become better teachers. One of the things that we want to focus on is feedback. Now, you may recall that feedback is a mandatory component of deliberate practice. For feedback to be effective, it needs to be timely, actionable, and individualized. Feedback is important to the learners because it allows them to gauge the gap between their performance and the expected performance. It allows them to have self-reflection, and it motivates them to improve. Now, with that in mind, my team and I set out to explore the quality of the feedback that physicians and surgeons within our department are providing to our learners. We analyzed close to 4,000 assessments that were performed over 5 years. And we specifically wanted to examine the quality of the narrative feedback, or the written comments, that the physicians are providing to their learners. We had some concerning findings. First of all, only 57% of assessments had any feedback documented. Second, the quality of the feedback was moderate at best. So with those results, we started to examine what did our physicians do well and what did they not do as well. So they did a really good job about providing learners with evidence for how their performance was. So they described what they did well and they described what they have to work on. But they really didn't provide learners with suggestions for improvement. Typical comments included, "Well done," "Nice job," "Works well with the team." Unfortunately, as you can all agree, these comments are really not helping the learners get to the next level. They're not providing with any guidance for improvement. When we looked at the trends over time, we saw that over 5 years, there's really been no change or improvement in the quality of the feedback that's being provided. Now, that's a concerning finding, but that can be explained by the fact that physicians and surgeons have really not been taught how to provide high-quality feedback. So what my team and I are focusing on is really the strategy of providing feedback on feedback. What that means is we're looking at ways of using technology, such as artificial intelligence technology, to automate the process of evaluating the narrative comments as the doctor is entering them in for the assessment of the learner. Imagine having a virtual assistant like you have spell check within Microsoft Word. That virtual assistant will automatically assess the quality of the feedback as the doctor is writing it. It will provide them with feedback on how to improve before this ever gets submitted to the learner. I would envision the time when every month all the members of the department get a report card or feedback on how well they do with provision of feedback. They would also have an idea of where they stand compared to their peers in the department. And I truly believe that competition is a really good motivator for continuing professional development. So how do we teach the surgeons of tomorrow? I believe we do so by using evidence-based educational strategies. Strategies that work. These include simulation-based training. It includes peer-based learning, video-based coaching, as well as provision of timely assessments with high quality and individualized feedback. By training the best surgeons, we will achieve the best patient outcomes. Thank you very much.